Welcome back. Let's jump back into our discussion about mood disorders. Your most powerful tool in these situations, besides ensuring safety, is communication. How you speak and behave can significantly influence the outcome of the call. We practice what's called therapeutic communication. This means communicating in a way that helps calm and support the patient rather than escalating the situation. The basics are straightforward: stay calm, speak softly and clearly, and be non judgmental. If you come across as anxious, angry, or sarcastic, the patient will likely mirror or amplify those emotions. Instead, use a gentle, reassuring tone. Even if the patient says something troubling or outlandish, keep your facial expression and tone neutral and compassionate. Active listening is critical. This involves truly paying attention to what the patient is saying or not saying. Maintain appropriate eye contact and nod or give simple verbal acknowledgments. I hear you. Paraphrase or repeat back what they've said to show understanding. For example, it sounds like you've been feeling really overwhelmed since last week, is that right? This technique not only makes the patient feel heard and respected, it also helps you assess their mental state more accurately. Validate their feelings. You don't have to agree with delusional thoughts, but you can acknowledge the emotions. I can see that you're scared because you believe someone is out to hurt you. That must be very frightening. Simple statements of empathy can build a bridge of trust. When it comes to de escalation, avoid confrontational approaches. Do not argue with a patient who is saying things that aren't grounded in reality. You won't talk them out of a delusion or a deeply depressed perspective in the moment. Instead, gently reality orient them if possible, or just move the conversation toward cooperation. I understand you don't want to go to the hospital, but I'm concerned that you said you want to die. We want to help keep you safe. Avoid lying or making unrealistic promises, e.g., don't promise that they won't be involuntarily admitted if they clearly need evaluation. Be honest that the hospital will ensure they're safe. Never belittle or dismiss what the patient is feeling. Phrases like snap out of it or calm down, you're overreacting are harmful and will break trust. Also, never threaten the patient with police or treatment. It's better to partner with law enforcement in a way that the patient sees everyone's there to help. Keep your body language non threatening. No sudden moves, keep your hands visible, and if you need to touch the patient, to take a pulse, for example, explain what you're doing beforehand. For instance, I'd like to check your blood pressure. Is that okay? It won't take long. This gives them some sense of control. If a patient is very agitated, you might try redirecting their attention. Sometimes giving a simple task can ground them. For example, handing them a pen and paper to write down what they're thinking, or asking them to take slow breaths with you. The key is to be patient. It may take several minutes of listening and gentle talking for a person to calm down enough to proceed with care or transport. Building trust from the moment you arrive by introducing yourself by name, using the patient's name, and making it clear that your job is to help them can set a positive tone. Even if ultimately you have to do something against their wishes, like an involuntary transport, maintaining respect and empathy throughout will often make the process smoother. Managing patient care and transport in mood disorder calls requires careful judgment. First, continually assess the risk level. Ask yourself, is this patient a danger to themselves or others right now? If you have a patient with suicidal ideation, they express wanting to die, or you're responding to a suicide attempt, that's an immediate high risk to themselves. Treat any injuries from an attempt. For example, if they overdosed on pills, that becomes a medical call for potential poisoning. If they cut themselves, control bleeding. Importantly, never leave a suicidal patient unattended. Even a brief moment alone could give opportunity for a fatal act. If you suspect hidden pills or weapons, have those removed. For a patient expressing homicidal thoughts or showing violence, that's a danger to others, including the crew. Ensure law enforcement is on scene and that the patient is secured before you attempt to transport. Your safety and the public's safety come first. Law enforcement can also help declare an involuntary psychiatric hold if needed. Depending on your region, police, physicians, or certain mental health professionals may have that authority. In some cases, despite verbal de escalation efforts, a patient may remain extremely agitated, uncontrollable, or combative. This is when restraint or sedation might be necessary, but it must follow your protocols and be used only as a last resort. Physical restraints, like soft limb restraints, can be applied to prevent the patient from harming themselves or attacking others during transport. Always use adequate personnel. It often takes at least 4 people, one for each limb, plus someone to manage the head, to safely restrain a struggling patient. Sudden restraint can be dangerous if not done with control and coordination. Once a patient is restrained, continuously monitor their airway and breathing. Never position a restrained patient prone, face down, as this can impair breathing, positional asphyxia. They should be supine, face up, or semi-recumbent with belts or straps as per your stretcher design. Chemical sedation is generally an ALS level intervention. Medications like benzodiazepines or antipsychotics, like haloperidol or ketamine, may be administered intramuscularly to rapidly tranquilize a dangerously agitated patient. As an EMS professional, you might assist your paramedic partner in preparing these or monitoring the patient afterward. If chemical restraint is used, be extra vigilant about monitoring. These drugs can depress respirations or blood pressure, so follow your service's policy on maintaining oxygen, airway adjuncts, etc. as needed. When it comes to transport decisions, essentially any patient with significant mood disorder symptoms needs medical evaluation. This is not something to be left at home. If a patient is calm and consents to care, great. Proceed with a normal transport, keeping them comfortable. But if a patient refuses transport, yet you believe they are not in a sound state of mind, for example, a severely depressed person who attempted suicide, or a manic person who is delusional and could inadvertently hurt themselves, you will likely need to initiate an involuntary transport for psychiatric evaluation. The exact procedures differ by jurisdiction. Some places have specific forms or law enforcement mental hygiene arrests, so know your local protocols. Typically, law enforcement on scene can help facilitate this by legally sectioning the patient for transport. It's a tough situation because you're essentially overriding the patient's will, but it's done for safety. Explain to the patient in simple terms that because of the risk, they need to be evaluated at the hospital. Choosing a destination can also be important. In many systems, the default is to go to the nearest emergency department. They will medically clear the patient, treat any injuries or medical issues, and have psychiatric specialists evaluate them. Some progressive EMS systems have protocols to transport certain stable psychiatric patients directly to specialized psychiatric crisis centers or hospitals, which can be more appropriate and free up ED resources. As an EMS professional, follow your protocol and consider contacting medical control if unsure. If the patient has taken any substances, pills in a suicide attempt, drugs, alcohol, or has other medical conditions, an ED is usually the right choice because they need medical clearance. Finally, documentation and handoff are crucial. Document the patient's exact words, especially if they expressed suicidal or homicidal thoughts. Patient stated, "I want to jump in front of a train." Those details are important. Also note your observations. Patient pacing, shouting, required physical restraint, etc. This information helps the receiving facility understand the severity and the rationale for any involuntary hold. When you give your turnover report, clearly communicate any suicide risk or aggressive behavior, any medications or substances involved, and any treatment you provided, including restraints or injuries sustained. This ensures continuity of care and safety after you leave the patient. In conclusion, remember that mood disorders like depression and bipolar disorder are not rare situations. They affect a significant portion of the population, so EMS will inevitably be involved in caring for these patients. The key takeaways are recognize the signs, know what depression and mania look like in the field. A depressed patient might be quiet, maybe suicidal. They need gentle support and a watchful eye. A manic patient might be loud, impulsive, possibly dangerous. They need a calm but firm approach and possibly external controls for safety. Scene safety is non negotiable. Always protect yourself and your team. Use police assistance, remove dangers, and don't hesitate to involve others when a patient is beyond verbal calming. And never forget to consider that what appears psychiatric could be a medical issue in disguise. So do your due diligence with assessment. Communication is your best tool. Time and again, the way we communicate can make things better or worse. Use the skills of empathy, active listening, and clear, non threatening speech to diffuse tension. Small things like showing respect, addressing the patient by name, and simply not judging them aloud or in attitude go a long way. These patients are in crisis. As the saying goes, the patient may not remember what you say, but they will remember how you made them feel. Make them feel heard and safe. EMS's role is critical. You might be the one who prevents a suicide by recognizing the warning signs and intervening. You might be the one who keeps a manic individual from hurtling into a life-threatening situation. By getting these patients to the care they need and doing so with compassion and professionalism, you truly are making a difference. Mental health emergencies are just as urgent as physical ones, and our duty to care is the same. Join me in the next lecture to apply what we have learned about mood disorders to some case studies we may see in the field.